Now we're in EKG. I want to first go over a little bit of physiology. That is not an egg, that is the heart. If you did. So we know right atrium, right ventricle, left ventricle, right? And then we're going to put in there the conduction system. So our conduction system starts here in the right atrium. And then the energy from the right atrium circles around the atria and then goes to the septum. And then it stops here at the junction, which is called the AV node. And then it goes down through the bundle of His, right? And then it splits here in the left ventricle to the left bundle branch and then to the right bundle branch. And then you have your Purkinje fibers here. Okay, I'm going to label them in a minute. So SA node, sinoatrial node. And then inside here, we have the AV node. And then again, I want you to also remember that this is the junction. So atrioventricular node. Junction, because sometimes they'll say junctional tachycardia. That's the AV node. Okay. Or an AV block. That's in the AV node. And then you have your bundle branch. So you have the right bundle branch on this side. And then you have the left bundle branch on the other side. Okay, and then the Purkinjes. Okay. Now, when we're looking at the EKG, we have either 3 leads or we have the 12 lead, right? We have the 5 lead or the 4 lead, but really it's just the 3 main leads that we're looking at, okay? So in those leads, smaller here. So we would put 1 lead here, right? So you have a lead here. And then from that lead, and then you go here on the other side. So this could be like in the arm or the chest, right? And then you have another one kind of at the tip here. Those are the little patches, right, that we put. And then I'll draw a diagram here in a minute. So what are we actually measuring when we do this? So this up here measures lead 1. Okay, so it's not the 1 point, it's the 2 of them connecting that's capturing the energy up top into lead 1. Okay. And then you'll have 2 other leads, right? So lead 2 is what measures actually, sorry, this is lead. Yeah, no, that's right. Here, from here to here is lead 2. Okay, that captures lead 2. I'm going to give you another concept in a minute here. And then over here is lead 3. Okay, lead 3. The energy in the heart is more negative here at the top and more positive here at the apex. Okay, what does that mean? The energy that you see on the EKG, it's the higher that is, the more positive, right? So like in a graph, you have positive and you have negative, right? So the negative values will be meaning that the rhythm is smaller because it's more negative, and it's going to be taller if it's more positive. Okay, we'll illustrate that later on. Now, if we are using precordial leads, and precordial leads are those that we put when there's a 12 lead, okay? Well, the precordial are the ones on the chest, okay? And then you have the 4 for the extremities, right? So the precordial leads basically measure or look at the ventricle, okay? So we see them, we put them, V1 is on the right side, right? If we were putting the EKG, it will be on the same area where you would listen for the aortic valve, right? Second ICS, right cellular border. And then the rest of them is going to be on the left side. So V1, V2 looks at the right ventricle, okay? V3 and V4 looks at the septum, but the V3 is more on the right, V4 is more on the left. Okay. V5 and V6 looks at the left ventricle. Okay, so that's more here, V5 and V6. Okay, so if we were looking at a 12-lead EKG and we're looking at a STEMI, right? What is STEMI again? ST elevated MI, myocardial infarction, right? We will see where that STEMI is at, and we could tell which part of the heart is affected. Where's that MI happening? Is it on the left ventricle or is it in the right ventricle? Okay. You follow me so far? Okay. So when we're looking at different angles. So we're seeing the rhythms a little bit differently because you're looking from different angles, kind of like cameras from different angles, right? So some will look at the back, some will look at the front. So that's, but basically this is what we're looking at. Now, let's look at what rhythms we actually see when we're looking at the EKG. So I mentioned that here's the SA node, and of course in the SA node is the P wave, right? So when the SA node fires, then we're reading the P wave. As you guys get more comfortable with EKG, you'll know that this little tiny P wave may look differently. And if it looks abnormal and different, that means that that conduction of the P wave did not come from the SA node. It came from somewhere in the atrium, but not from the SA node. How do we know that this is a normal looking P wave? If we split that P wave into 2, it's equal. Okay? And it's round. It's not pointy, it's not pointing to the left, it's not pointing to the right, it's not upside down. Okay, so I'll give you the basics at some point today. Okay. We'll just go through the normal for now, okay? So P wave is that, you know, how it looks, and then we also look at the PR interval, right? So the PR interval is from the beginning of the P wave to the beginning of the QRS, right? So the PR, so we call it PRI, PR interval, is the time that it takes for the electricity to travel from the SA node to the AV node. Okay, And the normal time that it takes should be, anybody know? Normal PR interval? So 0.12 to 2.0 seconds. Okay, I'll give you some context as to how to measure that in a minute. I'll come back to it. Okay, but for now, just know that it's normal is 0.12, so 0.12 to 2, basically, okay? 0.12 to 2. And then from the PR interval, now the conduction is going to travel from the AV node to the ventricle, right? And it's going to start with a depolarization, right? So the depolarization of the ventricle creates the QRS. So the QRS is not always going to have a Q. So it's from that dot there, QR, S goes down to negative and then goes back to the baseline. This is the ST segment, and then this is the T. We didn't talk about the T yet, but let me break it down for you guys. So the QRS complex is again from this here to when it returns to baseline. Okay, that's the QRS complex. Now, depending on where in the 12 lead we're looking at, it may be just a R, it may be just a QS, but we still call that the QRS complex, okay? So the QRS complex is the contraction of the ventricle, okay? And the normal time that it should take for the ventricle to contract should be anywhere from 0.6 to 0.12 seconds. Why is the other one so long? Oh, this is the PR interval? Because it's starting from the beginning of the contraction of the atrium to the time it goes to here. This is just the one contraction, and then you measure the other things here. But I don't know, say, God said. All right, so that's this, right? And then, so one thing that I didn't put on here yet is the baseline. So we'll put the baseline in the gray. So the baseline again is basically where this line is, right? And I mentioned to you guys that anything above that line is positive. Anything below the line is negative, okay? That will make more sense later on when I talk about the junction, hopefully. So when we're looking at the ST, so now here comes the ST segment. So the ST segment is from when the S returns to the baseline to before the T begins. This is the ST segment. Okay, the ST segment we don't measure in distance, we measure it in elevation, right? That's why we call it a stemming. So it's either it's elevated above the baseline, or if it's depressed below the baseline. I'll talk more about that in a minute. Now when we go into the T, so it's still in the ventricle, but the T, and I'm gonna separate the T out. So normal T is like that, right? I'll put so the T is measured in height. Okay, so the T wave. And the T equals the ventricular repolarization. When meaning the heart is supposed to be, the ventricle is supposed to be resting, right? T wave is supposed to be, is resting. However, why is it still elevated? Any idea? Why is it not flat? Remember, the higher the wave, the more positive the energy. That means that there's electrical flow, okay? The higher the wave, there's higher flow of electricity. Let's write that down. Some concepts, okay? So, and then I guess I'll do the squares too now. So the horizontal line equals time, okay? How long something takes, okay? The vertical line is twofold. So vertical line tells you the amplitude of electricity, right? How strong that electricity is. So again, if it's below the line, negative energy, right? Above the line, positive energy, very strong. But this also tells us whether there's a infarction, an ischemia, or infarction. Okay. So a small square one big square, let's start with one big square, has has 5 small squares inside. So 5 small squares, so basically total of 20 small squares, right? Inside a big square. Okay. And so each big square, no, let me start with the small square. Oh, yes, thank you for your excellent math skills. Each small square equals 0.04 seconds, okay? Each big square equals 0.2 seconds. And this is horizontal, this way, okay? Because it's time, right? Or this is time. So that's how long it takes for electricity to travel. Now this usually, again, is amplitude, but we're also looking at millimeters, okay? So each small square is 1 millimeter. Okay, so obviously one big square is 5 millimeters. So we use the small square in millimeters when we're talking about the ST elevation or ST depression. Okay. A ST elevation or ST depression of greater than 1 millimeter is what may be more significant. Some books will tell you 2 millimeters. If it's less than 1 millimeter of a depression or an elevation, yeah, maybe okay, maybe not. Okay. I alluded from the Q wave. Let me add the Q wave because I mentioned to you that there's not always a Q wave, right? So the Q wave, so I'll put a Q wave here. So I'll put a complete wave. So here's the P, Q, R, S, go back to baseline, ST segment, T. Okay, so here's the P, P, Q. So this Q here is significant. Okay, I'll tell you how you know in a minute. R, so R, if you notice, is the highest amplitude, right? Because that's at the peak of the contraction of the heart. Okay, and then S, and then the T. So let me go back to my question here first, and then I'll come back to the Q. So why is there still electricity in during rest? It's because the electrolyte that's supposed to go back into the cells are still active, right? Which electrolytes is that? Potassium, right? Because that's intracellular, right? So when we're looking at the T wave, and if we're seeing that the T wave is very tall, okay, and I'm gonna put the R wave just for comparison because that's what I use to compare it to. Here's the R wave, ST, okay, R, and then here's the T. So if the T wave is high, which we call a peak T wave, right? It could mean two things, generally two things. You have to look at whether it's diffused or not. When we say diffused, that means that, are you seeing it locally? Remember how I talked about the leads here, the precordial leads? Or are you seeing it in all the leads? Okay, so if it's diffused, meaning in all the leads, all the 12 leads, even all the 3 leads, okay? Then this is hyperkalemia, right? Because potassium is intracellular, and so even during rest, you're seeing that high level of potassium in the myocardium, okay? In all the leads, leads 1 through 12, you're seeing them all peaked. As opposed to it's localized, meaning it's only in V1, it's only in V5, it's only in V4. Only few precordial leads. I want to be, specific. Okay, so that's from V1 to V6. When that's the case, that actually could be an infarction, an MI. Okay, so MI doesn't just manifest itself as an ST elevation. It could also be a peak T wave. Yeah. No, you do a MI workup. Yeah, troponin. Yeah, look at the history, aspirin, Mona. Yeah. So now the opposite happens when the T wave is flat, right? So if it's flat or if it's inverted, okay, so the same principle is applied. So if it's flat or inverted, then you also want to look at, is it local or is it diffuse, right? So if it's diffused, meaning again in all the leads, all leads. So this is hypokalemia. Okay. Yes, but not a T wave, dysrhythmia. So hypomagnesemia initially will show up as a PVC. And then it could lead to a full-on VTAC. Yeah. And then hypercal could lead to a systole, because there's so much of the electrolyte inside that it's so rigid, the muscle is so rigid, it won't move anymore. That's why potassium is given as an IV push in death row, right? Because you're ceasing movement of the muscle. Okay. So if it's local, then this is a ischemia. So that tells you that there's a part of the coronary artery that is blocked, right, from atherosclerosis. Maybe because the blood pressure of the patient is high at that time, that you're seeing it as an ischemia, or if you're doing like a stress test, then you'll see that inversion of the T wave. Okay. All right, so back to Q, because Q is pretty simple. So a deep Q wave, and when I say deep Q wave, I mean greater than 5 millimeters negative, below baseline. Okay, so a deep Q wave that is greater than 5 millimeters below baseline is a sign of an old infarct. This patient had a history of MI in the past. Okay, either a silent MI or a not so silent MI. Silent MI is when they get a heart attack, but they didn't know it. I meant to say lower, so -5, but yeah, greater than 5 millimeters, but below the baseline. Thank you. So that's what I mean to say negative. No, you're measuring this is the Q, right? So this is the Q. So from the baseline, it's 5 squares deep. Okay, so it's 5 squares deep. Okay, that's what we call it, a deep Q wave. Or an inverted Q, right? Inverted Q. But not all inverted Q is a sign of an MI, only if it's this deep or deeper. Nothing. The QRS. Remember, it's part of the QRS complex. So then you will measure this from the beginning of the Q to the time that it comes back to the baseline from the S. That's your entire QRS complex. So, but that's, remember, width. That's horizontal. This is vertical. Okay, so we're measuring vertical in millimeters or in amplitude, or we're measuring width. That means that it took longer for electricity to flow through the muscle or that part of the heart, the myocardium. Okay. So let me also go back to your QRS, because this is I want you to remember something important. So in your QRS complex, we say this is normal, right? So therefore, if the QRS is greater than 0.12 seconds, then we're considering that a wide QRS, right? And that is the only time that you're calling a rhythm ventricular. Okay? That's the only time that you're saying there's a ventricular problem. Okay? I want you to remember that, because when you start seeing EKGs, there's going to be so many different waves, right? Only when the QRS is wide will you say that this is, let's say, a ventricular tachycardia. Or, Say again? We'll start with PVC, which is, it could be hypomag, hypocal, hypoxia, hormone deficiency. What did you guys say? Bundle branch is different. Okay. But in an RBB, yes, there's also a ventricular, a QRS widening, but you'll see a rabbit ears, right? So bundle branch block, that's a little bit advanced, but we'll go ahead since you mentioned it. We'll put that here. So a right bundle branch block, RBBB. We don't call it ventricular because we already know the right bundle branch is in the ventricle, right? And so what happens in, as far as the wave that you'll see, you're gonna see it, so here's the P, then your Q, right? And then you're gonna see an R, and then it's gonna bounce back, and then you're gonna see a bigger R, and then it goes to your T, right? So they're called rabbit ears. Why? So this is what happens in a bundle branch block. The conduction system is flawed somewhere in the right bundle branch, right? So what happens when the electricity flows through the bundle, so it goes here, right? But then, oops, it's blocked. Let me bounce back, find a different route, and then continue. That's why there's two R's. And the bounce back is when it became negative. Because remember how I said the flow of electricity in the heart is negative at the top, positive at the bottom. So when it bounced back, when it went back like that, you see the wave go down. And then when it found a new route, which is going towards this way again, towards the apex, then you see it go up again. Okay, very benign, nothing to worry about. Unless it's causing some kind of perfusion issue, such as a tachycardia, syncope, chest pain, tachypnea, stuff like that. What's more concerning is a left bundle branch block, okay? Because a left bundle branch block tells you that there's a problem in the conduction in the left ventricle, which is the part that is responsible for cardiac output, right? So that can turn into a more abnormal rhythm. Okay, but RBBB, and you may not see it. Sometimes you see it in a lead too. Sometimes you have to get a 12 lead in order to see it. It may not be as recognizable. Medication that could cause a wide QRS. It's not so much the medication that will cause a wide QRS because that's abnormal, right? But usually a wide a QT prolongation is what we're worried about, because so going back to our rhythm here, here's the Q, right? Here's the T, and a QT is measured from the beginning of the Q to the end of the T. So when that's prolonged, then it leads into bradycardia, right? Because it's taking a long time for the electricity to go through the ventricle when it fires and then when it relaxes. So a prolonged QT, your antipsychotics can cause that, your opioids can cause that. When the QRS is prolonged, again, apart from the PVC, then again, it could be an electrolyte issue, hypoxia, hormones, such as in females, the estrogen depleting can cause that. If we were looking at medications, it would be the medication that will cause bradycardia. Let me say basic 3 lead, right? When we're reading 3 lead. And I wouldn't want for you guys to start memorizing how they look. I really would love for you to just methodically go through each step that I'm going to put on here, because you can't go wrong when you go by the steps. You can't go wrong. Okay, it's just like it's a process of elimination. It's like, A versus B, because I'm going to outline it for you guys, that it makes it a little bit, hopefully, easier to recognize the patterns based on description, not based on how they look, but I will draw some of it as well. So the first 2 things that we look at is rhythm and rate, okay? So rhythm, is it, when we do rhythm and rate, we are assuming first that we are looking at the ventricle. So meaning we're looking at the R, okay, the R wave. But it's also possible for us to look at the P waves and get the rhythm for the P wave and the rate for the P wave. Okay, so I'll go over that. So regular, so we'll put as far as the P to P, P to P is the same all across the EKG, or the R to R, this is the same. Okay, so how does that look like? You would measure, so here's the P, and then you would look at the next P. Okay, so when we're measuring P to P, so you're getting, you can use either a caliper, or I just use paper, really. And then I measure from the, oh, that's wrong, that's not from the peak, but from the beginning. Okay, from the beginning, let's correct that. So just to learn it wrong. So from the beginning of the P here, and then the beginning of the P here, and then I would normally like get a paper, mark that on my paper, and then march it out on the rest of the rhythm. Okay, so this is your P to P. Now, when we're measuring the R to R, you're measuring the tip of the R. Okay, so that's the R here, and then the R here. Okay, so the R to R. And same thing, you're measuring, are they all coming at the same time? Are they all being fired at the same time? Okay, so when you say P to P and the R to R, they're the same, that's a regular rhythm. Now, a regularly irregular rhythm, right. So when we say regularly irregular, it's regular, 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 and then there's an irregular, okay? So commonly, these are your premature rhythms, okay? And how do they all differ? It could be a premature, I'll write them down here and tell you how you could distinguish that. So if it's a premature atrial contraction, then the one PQRST is early. Okay, but it's a normal PQRST, but early cycle. Okay, I'll draw that in a minute. With a PVC, I'll jump to the PVC first. So with a PVC, premature ventricular contraction, wide QRS, okay, likely if it's a wide QRS, there's no P, okay? And it's not that the atrium didn't contract, but it's because the QRS rhythm is so wide that it's hiding the P behind it. So you don't see it on your rhythm, okay? So no P, wide QRS, there's gonna be no T, okay? And it comes early, okay? Because they're all premature, okay? Now for a PJC, so premature junctional rhythm contraction, which we know now is in the AV node, right? So then here, there is no P, okay, or upside down P, inverted P. and the QRS is normal. Okay. So criteria-wise, these are the criteria for the premature beats. So PAC, again, they're all the same, except that one would be a little bit sooner than the other. So for example, we have our EQRST, and then the next one is supposed to be right here. And then you get the T, but then right away you see the P here. Okay, so this one is premature because it came sooner. This cycle is premature. So if you were to march it out for your P wave here, the P wave here, and then this P wave, you'll see that the distance here is shorter than this distance, right? Or if we were to march out the R and the R, and then this R, again, this is shorter because it's premature. Okay, but everything else is normal of your R to R. Okay, so then you're saying this is regular, irregular. Okay, so for all of them, it's going to be like that. So for PJC, how that looks like, and I'm just going to put 1. So it's easier to distinguish this one. It could be like this. Okay, or it could be like this. Okay, so what's abnormal? No P wave here or inverted P wave here. So it's either one, P or R. They're shorter. Because here they're supposed to come at the same time, right? Yeah, so this came a little bit sooner than it should have. So for example, let's say you were counting the squares, right? And let's say here there were 15 small squares. And then let's say the next one is 15 small squares between the R to R. And then the next one is 10 small squares between the R to R. So that means that the QRS complex came earlier. But if it has a normal P, normal QRST, then that's just a PAC. So it's pretty benign. So with these two, one thing that you guys want to notice is that the QRSs are normal with the PAC and PJC, because remember what I said, the rule is that only if the QRS is wide is the only time that you will call it ventricular. Okay, so if the QRS is narrow, that is not ventricular anything. So PVC, you have a normal cycle, and then all of a sudden you see this huge thing here, and then back to the normal cycle. Okay, so wide QRS, and because the QRS is so wide, the P wave is probably somewhere under there. You just can't see it. Okay, because all you're seeing is this very wide QRS. Okay. If a PVC continues on, and it becomes like 3 series of PVC, then that's called the VTAC run. Okay, or a PSVT, paroxysmal PVC. If it becomes 4 or more, that may lead to a ventricular tachycardia, because they're all VTAC, as they're all going to be wide like this, because you're calling it ventricular. And we'll get to that. Just giving you guys a preview. So these are premature. Okay. Now, if it's irregularly irregular, so usually the two things. Sorry, I'm thinking. The main thing, I'm sure there's other ones. That's why I paused, because I'm sure there's other ones and I can't think of them right now. But the possible rhythm that this could be is AFib. Okay, so in AFib, There's other criteria, and it'll come when we look at the AFib there later on, the P's. So you have, these are the P's. And then you have a normal looking QRS. Normal looking QRS. 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 Okay. Irregularly irregular. So the R waves don't have any type of pattern whatsoever. Okay. So when you hear yourself say, okay, I don't see any pattern, it's not like regular, regular, irregular, right? It's irregularly irregular. That's possibly a fibrillation. Okay. And actually, let me correct that because it's possibly a fibrillation. Now, if it looks like this and the QRSs are narrow, then we said that if it's narrow QRS, it's not ventricular, right? So then that's likely atrial. Okay. But if the QRS are wide or undistinguishable, so basically the rhythm is very disorganized. So that's a key word. There we go. So here, if it looks like that, okay, wide or undistinguishable or very disorganized, okay, that's ventricular. That's a VFib. Okay. Yes, very, yes, absolutely. Okay. You follow so far? So we're looking at the rhythm. Is it regular or irregular? If it's regular, that's probably an NSR, normal sinus rhythm, but there's more criteria. Okay. If it's irregular, you're asking yourself, is it regularly irregular? You have regular, 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 and then irregular. So that's likely a premature contraction. And then you look at, well, what's wrong with it? Do they all look normal? PAC. Is the P wave flat or upside down, but the QRS is still narrow? PJC. Or is the QRS wide? PVC. Okay. Now in the rates, pretty easy. I call this the last name of the rhythm, right? If you know right away, is this a slow rhythm? Okay, that's something Brady, right? It could be atrial, it could be junctional, it could be ventricular, but it's a Brady or tachy. This is something tachy, okay? And of course, if it's normal, then that's a normal sinus rhythm. It's coming from the sinoatrial node. And then we'll look at the P wave. Is it a normal looking P wave? So if it's a normal looking P wave, then we know that it's a sinus wave. Okay, it came from the SA node. Now, if it's pointy, or they have different shapes, but they're all upright, meaning they're not inverted, then that's not coming from the sinus, it's coming somewhere from the atrium. So here's how that would look. So let's say that we have an irritable, so here's the SA node, right? So this would give you a normal looking P wave, but let's say you have an irritable area, an irritable focus on the left atrium here. So if there's a P wave that comes from there, it may look pointy like that, okay? Or you may come from here and it looks like that. Okay, so these are abnormal P waves. And if it's a P wave, it came from the atrium, right? But it didn't come from the sinus because it's not normal looking. You follow? Okay. And then, so yeah, so that's atrial. Now, if it's worm-like, again, or indistinguishable, then that's this one here. That's the atrial fib. Okay, this one. So that's when the atrium is just fibrillating. It's just quivering like that. Okay. And so that criteria, along with the irregularly irregular, are the key words, the words that you would associate in a test question to AFib. Worm-like or indistinguishable P wave plus irregularly irregular rhythm. It doesn't matter the rate, okay? Because AFib we can categorize as AFib with tachycardia, or RVR, rapid ventricular rate, or AFib with controlled rate. Don't worry about that part. That's not part of the criteria, okay? Worm-like P wave, can't see them, and irregularly irregular rhythm, okay, is AFib. And then if they're absent or upside down, as I mentioned earlier, then it came from the junction. So remember how I mentioned that the electricity in the heart is more negative at the top, and then it becomes more positive the closer it gets to the apex. So when you have a junctional rhythm, what happens is at some point the SA node didn't fire, right? And because it didn't fire, then what's going to pick up the rhythm? The AV node, right? But the AV node is at the middle. So then what it's going to do is it's going to fire electricity this way, but at the same time, it may backfire electricity this way. And that's why it's negative, right? That's why it's upside down. Because now the electricity is going back to the negative instead of positive, right? Yeah, it's going to be an inverted wave. I've never seen that. Because again, Q usually is for scar tissue. Yeah. But yeah, so that's your Q. Okay. Now here's the other thing. You may not see this as hold on, let me just finish my thought. So you might even see like this, right? And then here's your T, and then on top of your T, you might see a little knob like that. That's your P. Yeah, because you don't know when it's gonna backfire, right? So it fired this way, and then the electricity coming back was a little late, so you see it here. Okay, you don't see it here. Okay, so that's still a PJC or some kind of junctional rhythm. Okay, sometimes you'll see that close to here. Okay, or sometimes it's just absent, there's no P wave. So if there's no P wave, that likely is a junctional rhythm. So let's go back to the rates for each, okay? So because that will answer your question. So we know that the SA node fires at 60 to 100 beats, right? And then your AV node, if it has to pick up, has a rate of how much? 40 to 60. Okay, 40 to 60. And then if your Purkinje or your bundle branch have to pick up, then that rate is going to be less than 40, right? The lower it is in the heart in the conduction system, the lower the rate. Okay, because it's coming from 100 down, 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 down. So if you're seeing like maybe 30s, you know it's probably somewhere in the junction, well, a little bit closer to the junction still. If you're seeing a rate of maybe 20s, you know that's somewhere down here. Okay. which is not good, right? So this is about 20 to 40 in between. Pacing, but we'll talk more about that in a minute. So how does that relate to your question? If this is a little bit advanced, but just to answer Jose's question, okay? Because the junction can only fire up to 60, anything beyond 60 that has an upside down and inverted P is considered junctional tachycardia, because it's above the normal rate of the junction. Does that make sense? Yeah. But you know, the criteria is that it's inverted or flat P wave, but faster than 60. Okay. While we're at that, because I don't think I have it. It's quite categorized in each of these, but I'm gonna go ahead and add it because let me add it to here actually, and then I'll come back. So junctional, this is more inverted, but again, it could be flat. Okay. Now, if it is absent, so here, this is inverted or flat. Now, if it's just absent, it could also be supraventricular. Okay, so supraventricular, you're saying that so there's two criteria for SVT. Okay, we're not gonna call it ventricular. Why? Because the QRS is narrow, right? But we're not gonna call it atrial either because there's no P wave. So an SVT is a fast rate with no P wave and normal narrow QRSs. And what we're saying is that conduction is coming from up here. We can't call it atrial because there's no P. We can't call it ventricular because the QRS is narrow, but it's coming from above the ventricle for sure because the QRS is narrow and it's fast, greater than 100. So then that's an SVT. Okay. Did I confuse you? Let me show you how it might look. Yeah. Yes, yes, I shall. So an SVT, so then what you might notice is like, wait, is that a P or a T? Well, P is smaller, right? So the P, no, don't use sawtooth. I will show you what sawtooth looks like in a minute. The P disappears before the T because the T is bigger, right? So in a rhythm like this, and because it's so fast, you're not seeing the P, but you're seeing the T. So these are T's. And this would be more spaced out normally, okay? But it's gonna be a rapid rate, normal, narrow QRSs with no P, just the T. Because you know, you're not gonna see a P, you're not gonna see a P with no T, but you can see a T with no P because the P is smaller, T is bigger, right? Exactly. So the P is hidden behind the rapid QRST. Okay, so flutter we haven't talked about yet, but we will now because you guys mentioned it. So here, okay, so here we'll talk about flutter because flutter, I'm not actually there yet, guys. So actually, no, I'm gonna defer from talking about it until we get to the next criteria, which is right below. We're getting there. Okay. But just know first that if the shape is different, it's coming from the atrium, it's not coming from the sinus, right? And here, in an SVT, there's a QRS and a T, QRST, no P, and rapid rate. Okay, Usually if it's SBT, it goes above 150. Okay, because the sinus can only, above 120, sorry. Because the sinus can only run up to 120. Okay, so sinus rhythm, sinus tachy, usually up to 120. SVT, greater than 120. Okay, VTAC, 150 and on and up. Okay, so here, next criteria. So far we said rhythm, regular, irregular, rate, is it normal, is it brady, is it tachy? Then we'll look at the P wave, how does it look? Is it normal looking, or is it pointy, or is it worm-like, or is it absent, or upside down, inverted? So now another question we want to ask ourselves is it just a ratio of 1P for every QRS? Okay, if not, two possibilities commonly. Okay, I'm sure there's more. If not, there's more P's, okay, than the QRS, then what you have is an atrial flutter. Okay, so how does that look? Abnormal P, QRS, abnormal P, QRS, abnormal P, QRS. Now here, you notice there is no T. Why? Because these abnormal P's have covered them. Okay, because there's more P's. So then we count this. This is a 2-to-1 conduction because there's two P's and then one QRS. Okay, or it could be P, QRS, right? P, QRS, P, QRS. Now, normally also, what you'll see for a flutter is that the rhythm is regular. Okay, so the R to R rhythm is regular, but there's more P's. Okay, now in a situation wherein the rate is Brady and there's missing QRS, okay, so how that may look is you have this PQRS, right? And then you have PQRS, and then you have this P, no QRS, and then another P, and then a QRS. Okay, it skipped it, but it's not a skipped beat because a skipped beat is missing the whole cycle. Here, you're just missing the QRS, but you have a P, right? That's an AV block. Okay, so now that's one criteria for AV block. So what you're doing is you're like collecting your clues as to what the rhythm is. Okay, and they all come together. So now we go into the PR interval. So in the PR interval, we're looking at, is it normal? And how much is the PR interval again? 0.12 to 0.2, which is, if you like just looking at the squares, that's 3 to 5 small squares. 3 to 5 small squares, or no bigger than one big square. Okay, so from the beginning, where did we put our PR interval? PR. Didn't I draw one? Oh, here you go. So from the beginning of the P to the beginning of the QRS, it would fit, let me put it in this square here. 5 small squares, right? So then let's say you have your P here. Oh, wait, no. That's a P, and then your QRS would have been like that big. Okay, that's wrong. PQRS, like giant one. So from the beginning of the P to the beginning of the QRS is less than or just about the size of the big square. Okay, or 3 to 5 small squares. That's the correct PR interval. So what does that mean? That is the time that it takes from the conduction to travel from the SA node to the septum, around the atrium to the AV node. Okay. Now, if it takes longer than that, there's a problem before it goes to the QRS. There's a problem in the junction. There's a problem in the AV node. That's why it's called an AV block. Okay. So it takes longer for it to get through the AV junction here. So what are the different types? We're going to focus on the prolonged ones, okay? Because that's commonly what you guys are asked. So you ask yourself, is it consistently prolonged? Meaning they're all just prolonged, but they're all the same distance, okay? All same PRI distance measurement, really. But they're all long, okay? So that is a first degree AV block. That is the only problem in the first degree AV block. Okay. Now, if it is prolonged, so prolonged, no, progressively prolonged, meaning I call this it's long, and then it gets longer, then it gets longest, okay? And then you have a drop plus drop QRS. So technically this is called, there's a non-conducting P wave. Basically this one here that we talked about, okay? This is a second degree type 1 AV block, otherwise known as Winkelbach. So what's the criteria for a Winkelbach for a second degree type 1? It gets longer and longer and longer. The PR interval gets longer and longer and longer. Okay. So how would that look? So you have PR interval, QRS, right? T, PR interval, QRS, T, PR interval, QRS, T, PR. And then it starts with, that's wrong. It starts with a P again here. I'm gonna start over. Anyway, PR, QRS, so like, oh, okay, that looks normal. And then you have a little longer. Okay, and then you have a little more longer. And then you have another P, no QRS, P again, QRS. And then it starts over, the cycle starts over. Okay, so what's prolonging? This. Okay, so how you would measure that? Again, you could measure it with a caliper here. There's nothing, drop QRS, right? So what's the prolonging, right? Prolong, progressively prolong, long, longer, longest drop, and here's the drop. Okay, and then it starts over again. Long, longer, longest, drop. If it doesn't follow that pattern of it prolonging, that is not type 1. Okay, that is something else. So what is the something else? If the PR interval is consistent, so this is key, consistent, same measurement, right? Either normal or prolonged. Okay, plus the dropped QRS. QRS, or in a test question, it might say it as a non-conducting or non-conductive P wave. There's a P wave with no QRS, okay? This is your second degree type 2 AV block, which is otherwise known as Mobitz 2, okay? Winky block, by the way, is also known as Mobitz. It's called as Mobitz type 1. Okay, you follow? Here, it's normal distance in all of them, right? QRST, P, QRST, and then all of a sudden you got a P wave, nothing, and then another P wave, okay? But the distance between all your other PRs would be normal, okay? Either consistently long, so they're all, let's say, 0.22 or 0.24, or they're all 0.2, but they're the same, okay? Which do you think is more dangerous? Second. So in AV blocks, the higher the degree, the more deadly, okay? The higher the degree, the more deadly. And of course, the highest degree is the third degree block, right? So we're gonna add third degree, and then I'm gonna move to a different section. So we've asked the no question, consistently prolonged, that's first degree block, progressively prolonged, that's second degree type 1, consistent, either normal or prolonged, so the keyword is consistent. Okay, plus the drop QRS, that's second degree type 2. So now with the next one, what we're looking at is the PR interval is very inconsistent. Okay. So the PR interval is very inconsistent, but the P to P rhythm is regular. The R to R rhythm is regular. Correct that. The P to P rate is normal, but the R to R rate is slow. And there might even be a wide QRS. Okay. So there's no, and a PR interval is very inconsistent. And also there is not one P for every one QRS. Okay. How does that look? So I'm going to draw them separately so you guys can see the difference. Okay. So here's the atrium. P, E, E, E. Okay. Here's the ventricle. Let's say, oh, this looks normal. Okay, QRS. 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 So if I were to measure the PR interval, this looks normal, but then this is very long, right? This is very long. This is like, okay, it's on top of each other. There's not even anything there, right? There is no rhyme or rhythm between the P and the QRS. The PR interval is very inconsistent. Why? Oh, And let's put the actual rhythm here. So this is third degree AV block. So here's what's happening in a third degree block. Remember how I said in AV block, the problem is the AV node, right? So in a first degree block, this fires, but then there's a little problem here, so then it's slow, right? And then that's consistent. It's just consistently slow. In a Mobitz 1 or second degree type 1, this fires, it goes through, and then it goes through the QRS. P, now a little bit longer than QRS. And then P, even longer than QRS. And then P stops there. No QRS. And then starts over. P, a little longer QRS, right? And then with second degree type 2, this is blocked, but you just don't know when it's gonna not let the P conduction go, the SA conduction go. Now, in a third degree, this is completely broken. Okay, so then I like to think of this as a divorced husband and wife. Okay, and of course, the wife will be the atrium, because it's a normal rate. You know, she gets alimony, right? So she has enough money. She's like, you know, I'm going by my daily life, right? Poor little ventricle over here, husband, has less money. So then, but he's doing his own thing, right? So they're doing their own thing with no communication whatsoever. He's a little slow. She's all right. You know, she is at the right speed, right? That's a third degree block. Now, over time, as you see that the rhythm will get slower and slower, right? That's why this is Brady, because this is a ventricular Brady, right? Over time, the ventricle is going to go into a VFib or will just go into asystole, right? And what's not being sustained? What is not happening when the ventricle is not contracting fast enough? No cardiac output, right? So that's why this is deadly. So then this requires an internal pacemaker. Okay, and we'll go through that once we're done. We're almost done with analyzing our EKG because we're almost at the ventricle here. So we've looked at everything that we need to, I think, look at with the P so far and the PR interval. So we're at step 6 here. So now we're going to go to step number 7. Okay, so now we look at our QRS. And this is pretty simple, right? We kind of had talked about it already. So is it either narrow or wide? Basically, that's it, right? So if it's not wide, so it's either narrow, so you don't call it ventricular, not ventricular rhythm, possibly atrial, possibly sinus, atrial, or junctional, but not ventricular. Okay, and then you will use the last name, which is the Brady, tachycardia, or normal, right? That we talked about earlier. And then is it wide? And again, wide is greater than 0.12 or 3 small squares. Okay, and that is a ventricular rhythm. Okay, pretty easy with the QRS. Just don't get confused. Okay, so then from this point on, the other things that we're going to be looking at are not really rhythm related. And we've already talked about the ST segment. Oh, actually, no, we didn't. So ST segment, so now is it elevated greater than 1 millimeter from baseline? That is likely, so that's an ST elevation, that's an infarction. Or is it depressed? Depressed meaning it's greater than 1 millimeter down. I should put up on the other one from baseline. That's an ischemia. Up or above or below, I should say. Above baseline, below baseline. That's an ischemia. Okay, how does that look? If you have a STEMI, so you have your P, Q, R, S. Instead of the S going back down to baseline, it stays there and goes down here. Okay, so that's your ST elevation. Okay. And then for your infarction, for your ischemia, so you have your P, Q, R, S. S goes back down, doesn't go back up until here. So this is your ST segment. So this is an ST depression. So again, if someone, let's say, was doing a treadmill test and we see this, then that tells us, okay, there's a blockage in the coronary artery, but it's not a full blockage. And when they're under stress, because of high blood pressure, it closes up, right? But then when they rest, it opens up again. So that's a coronary artery disease. Okay. And then the next thing, you just don't see an ST elevation, but you see the other signs of MI. Chest pain, shortness of breath, tachycardia, hypotension, positive troponin. They're symptomatic, correct? They're just not, you just don't see it in the EKG. Yeah. And then, if they have, then you look at their history, did they have high cholesterol? They probably are going to go into the cardiac cath and then they could see in the angiogram if there's any blockage there. And then we had talked about the T already, right? So the T wave, is it normal? Or is it peaked? Meaning too tall? Or is it inverted or flat? Right? And so again, if it's too tall, either hyperkalemia or infarction. Okay, and I mentioned diffuse versus local. And if it's inverted or flat, in the elderly, it's actually normal. Okay, they don't have enough electricity anymore because they're older. So flat T wave, so flat, not inverted, flat. Okay, if they have a flat T wave in the elderly, that's fine. Don't worry about it, as long as you don't have any symptoms. Or again, it could be hypokalemia or ischemia. And there you have it. That's how you read an EKG. So simple.